May I invite Dr. Chandramohan next, Additional Professor, Department of Surgical Oncology, RCC Trivandrum. With the kind attention of the forthcoming presenters, there are many people here who will be leaving by the Vande Bharat at 4:30, so we are at very short of time. May I request you all to kindly stick your stipulated time. Thank you. Over to Dr. Chandramohan next.
So good afternoon. Am I audible? Yeah. Yesterday evening, we all witnessed a very nice musical program by performers. And in fact, I like to point your attention to another program which happened here, which is organized by Srijan, Deepin and other people. And there is a meeting. If you look at various people conducting meetings, it was extraordinary. And I really thank the organizers for inviting me to this topic to talk about breast cancer, which I don't think I'm the right person to talk about, because I don't manage breast cancers in RCC. At the same time, this gives an opportunity to give some independent perspective, looking at the changes in breast cancer treatment which is happening in recent year. And so that I think I will be the best person to talk about breast cancer rather than talking my practice and glorifying it. And the one thing I appreciate in this meeting here is the way which the people coordinated here, surgical oncologists, then general surgeons, plastic surgeons, depending on all people are like a team. And unfortunately, this kind of music, which is actually a symphony yesterday, if you get into Vande Bharat Express and go to Trivandrum, there you don't see such kind of interaction, cooperation. And then the symphony becomes a cacophony in Trivandrum. But I really appreciate the team and salute you. Going to the topic proper, so I am supposed to speak about breast cancer, the changes in management, and the time allotted to me is 12 minutes. I'll finish in 10 minutes. 2 minutes belongs to ASI. And I'll be going through the breast cancer scenario in Kerala, the changing landscape of breast oncology, the brief overview of breast cancer surgery, current protocols of breast cancer therapy, principle of breast cancer surgery and actual treatment, oncoplasty and how to get trained. And I thank the previous speakers, Sunil as well as Mir Christine, giving some beginning for the topic so that I can cover it fast. Global incidence. See, this is a world map of cancer, and you can see that the number of cancers in this pink area is breast cancer. So majority, 82 countries. This is a information which comes from Lyon, France. This is called Globocan. And Globocan it comes every 2 years. If you want to get some authentic information about the statistics of breast cancer or any cancer, you please refer to this Globocan. And majority of the places, breast cancer is the number 1 cancer. And if you look at the deaths happening, yearly, nearly 6 lakh people die out of 22 lakh people getting breast cancer. And moving to Kerala, the breast cancer trends are soaring. Actually, the rate is around 50 per 1 lakh people. So 1 lakh women out of 50 women out of 1 lakh in a ASR, age Sundays ratio rate will get breast cancer. And when I calculated that with the population of Kerala, I understood nearly 7,500 ladies are getting breast cancer every year. And where are they going? From RCC, I can see that nearly 2,000, 2,500 are coming to, maybe 2,000 are coming to RCC and going to other oncology centers, maybe another 1,000. So majority, at least 3,000, 4,000 breast cancers are managed by our general surgeons, and they have to know about the latest nuances in breast cancer therapy. What is happening now? Mir Christine now told, doctor undergoing breast surgery, she's worried about lymphedema, and in fact it's a grueling problem. More than 10% of patients undergoing mastectomy will have a lymphedema, and it is very, very troublesome to face it, and sometimes you may get a secondary sarcoma also. And what is happening in breast cancer? We are integrating other therapies and reducing surgery, and so that the outcome is better. Previously, it was used to be only surgery, but around 1930s, the surgery started long back. I'll go to the history once again. 1930s, the radiation started. Then we started doing breast conservation with the radiation also, which also contributed to survival. The radiation therapy has contributed to 20% reduction in the recurrence rate as well as 5% reduction in the increase in the survival of breast cancer. But the new kid in the block is systemic treatment. Now, lot of drugs are being given at the diagnosis of breast cancer itself. So I remember nearly 20 years back, a doctor from NCI, his name was Richard Lau. He visited RCC and we are having a chat. And he said, doctor, there is a problem with the breast cancer in your area. In US, breast cancer is not a killer disease, it's a light disease. And we manage and people survive. But here when I look in countries like India as well as in Bangladesh, your cancers are killer cancers, very aggressive cancers. At the time, we never knew the answer for this issue. Now we know that in 2000, the breast has been classified into various subtypes by molecular classification. So breast cancer can be either luminant A, it's very benign naive cancer, to going to HER2 receptor positive, which again can be tackled with the herceptin, and then it goes to the triple negative breast cancer, which is really, really aggressive. So now we know that in India, at least 35% cancers we see are luminal, not luminal A, it's triple negative. That's why it's spreading fast and patients are not cured. And when you look at USA, more than 40%, 50% cancers are luminal A. So they have a good results. So now I think if you look at the modern breast oncology practice, it's not surgery alone. You have to have in the day itself you have to tell, because youngsters will come with breast cancer, the fertility has to be discussed, then pregnancy test has to be done, whether to know that lady is pregnant or not. Then BRCA mutation, it's universally has to be tested for all breast cancers, and the distress of the patient has to be assessed. And not only that, not even an elderly lady has the right to breast conservation. And going to the cosmetology, the surgical oncologist or general surgeon, knowing all principles of oncology cannot treat breast cancer unless you know the type of breast, the cup size, and so many things. So you need to know a little more things to treat breast cancer with oncoplasty. So this is the history of breast cancer I had to tell you. In the beginning, on the day of Hippocrates, he used to think that breast cancer is a systemic disease. Hippocrates thought that, disease is caused by four things. There are four humors of body. One is blood, second is black bile, then phlegm, as well as yellow bile. And he thought that this disease, breast cancer, is a disease, a black bile coming out, and somebody who is trying to operate the breast cancer should be a fool, because it is a systemic disease. Then lately, after some time, Dr. Henry Duran started believing, no, it's a local disease. We can treat it aggressively. Then during the age of Halsted, he started doing radical mastectomies, and he could cure 45% of breast cancers by radical mastectomy. But this person, Bernard Fisher, and one thing I'll tell you, all these legendary persons who did the practice-changing things in medical oncology and radiation oncology, all are surgeons. Bernard Fisher is a surgeon. And the surgeons should be really proud that we are really leading the medical fraternity as well as a lot of discoveries. So he started a protocol called NSABP, which is a greatest research program in US, which first proved that total mastectomy was just as effective as Halsted operation as early as 1970. Then again it told that by adding anteater lumpectomy was as effective as mastectomy. So this now from Halsted's time onwards, okay, we started believing breast cancer is going to be a systemic disease. It has to be treated with the systemic medicines. And now with the advent of newer drugs, so many drugs. If you look at the medical oncology practice, lot of drugs were used to give for metastatic lung cancers. The examples being the olaparib, PARP inhibitors, then CDK4/6 inhibitors, ribocyclib, almocyclib, then the herceptin, then TDM1 inhibitors. Lot of drugs are being tested, and earlier these drugs were in the domain of mainly metastatic disease. Now these drugs are not only came to the the adjuvant setting, many of the drugs has to be given neoadjuvant also before surgery. So, dear surgeons, before operating any breast cancer patient, you have to subtype it and find out with the molecular classification, are we going ahead with the operation, is it going to be the correct treatment for the patient? I'll come to that later. Again, these two legendary personalities, both of us visited RCC, and Umberto Veranesi, he started the concept of a quadrantectomy for breast cancer. Then Arnaldo Giuliano came to my meeting, which I organized in 2018 in Toronto, and delivered a lecture. And I also had the opportunity to observe him in Santa Monica in US, where he is doing sentinel node lymphadenectomy. So these people also pioneered sentinel node lymphadenectomy, sentinel node biopsies, so that the morbidity of breast surgery, axillary surgery, is avoided. So I have only 2 minutes left. Don't worry, I'll finish. So staging of breast cancer, it has to be staged either as early or locally advanced. Early breast cancer, locally advanced, okay, it has to go for neoadjuvant treatment, but early we used to operate first, but that is changing now. Breast conservation surgery is the norm. Cosmesis is one important aim as the reduced recurrence. And these are the various contraindications of breast conservation. I know it is written in Bailey and Love, all of you may be knowing it. Yeah, management of axilla. This is a modern management of axilla. If it is clinically negative, patient has to undergo sentinel node biopsy. It is clinically positive, patient can undergo axillary node dissection. And after post sentinel node biopsy, if 1 to 2 nodes are positive, by ACOSOC Z11 trial, you can observe. It is 3 more nodes are positive, you have to undergo axillary dissection. Coming to the post-chemo setting, all these patients post-chemo at present in most hospitals, including RCC, Tata Memorial Hospital, we do axillary dissection, but there are ways to avoid that by dual traces, more than 3 sentinel nodes or targeted axillary dissection, you can avoid axillary dissection as well. Again, the golden rule, please remember, early breast cancer, primary surgery, exception, it is triple negative, more than 2 centimeter, or HER2 positive, more than 2 centimeter, not positive, the patient has to have systemic therapy. For HER2 positive, the patient has to have either single or double HER2 blocker, and triple negative, the patient has to go for chemotherapy. And this is very important because the treatment has to start in the beginning itself, and not only that, when the patient had a disease, residual disease, this has to be given by, so treated by further chemotherapy. I am not going to detail. Oncoplasty is very well covered. I am not going to detail. Excellent class by Dr. Sunil. Thank you, sir. I deleted many of my slides. So this is my last slide. The training in breast cancer is very important. I think all surgeons and surgical oncologists, there are short courses, 2-day programs. If you look at the MVR, Dr. Annamani came and Dr. Sunil came, and they spent 2 days and they could do cosmetic breast surgery, oncoplasty. And oncology aesthetics, there are various programs in India, in Tata Memorial as well as Delhi Max, as well as many places. And if you want to know about details, I'll connect to that. And see, this is my last slide. Breast cancer incidence is soaring. Treatment de-escalation is the present day norm. Multimodal care is the theme. Breast conservation, oncoplasty are widely practiced. And training in breast cancer surgery is essential for breast surgeon. I hope that. So even if we have a lot many surgeons here, I don't think if you name a single dedicated breast surgeon in Kerala, we don't have. So a lot of opportunity for youngsters to get training and cure breast cancers. Thank you very much.
Thank you, sir.
Thank you, sir, for highlighting the importance. And I think this field is going to be kept away from the surgeon's domain. And soon, I think the surgeons may have to disappear, may disappear.
I think patients first, sir. Surgeons come next.
Thank you, sir. Move on to the next presentation.